It's very nice to see some familiar faces here, and also the national malaria programs that I've worked with over the past few years. I first want to extend my appreciation for the work that you've done to support the SEADOT study in your countries. And it's very important, this collaboration, because it needs us to work across, not only with the malaria program, but with the provincial health departments, district level, and even in some countries we're working with the military. And these are across departments of the government. So we definitely appreciate the work that you've done to support us. So I'm just going to go over, I think everybody here knows about the story about primaquine. We've been doing this for probably 15 years now. But just to tell you that, before 2018, we had one drug, and that was primaquine. And we had two doses. It was low dose or high dose. And I've just given the doses here. The 0.25 milligram per kilo per day, or they also call 3.5 milligram total dose. And it was given over 7 or 14 days. It seems like in Asia, it was mostly 14 days. And in South America, it was usually 7 days. But really, the most common dose is 30 milligrams daily over 7 days. Then we have primaquine high dose, which was recommended in places where there was chloroquine resistance. That dose is 0.5 milligram per kilo per day. Other people call it 7 milligram per kilo total dose. That is also given over 7 or 14 days. And the most common regimen is 30 milligrams per day over 14 days. I just also want to give you some data historically. So this data is from SMRU, where I worked along the Myanmar border in Tak province in Thailand back in 2010, excuse me. And this data is just showing that, also just to remind everybody, that was during a time when we did not routinely give primaquine. Really nobody in the area did. So we looked at artesunate monotherapy, chloroquine monotherapy, and then chloroquine plus primaquine. And this is a survival curve. This is failure. You see that a lot more people failed when they had artesunate or chloroquine, but when you add primaquine, you get much less failure, and it's massive. But this is not new information. Back in the 1940s, in soldiers who were returning from the Pacific and also the Mediterranean theaters in World War II. This is a study done in the USA on returning soldiers. Old medicines, but same concept. Chloroquine, you have a lot of failure or a lot of recurrences. And when they gave plasmaquine, which is the precursor to primaquine, you have much, much less recurrences. You see the same thing in here in Indonesia. So just want to say that this data is not new. And now we have tafenoquine, which is a 300 milligram single dose if you're more than 16 years old. And in children, there's a trial called the TEACH trial, where it looked at children more than 2 years old. The dose is approximately 5 milligram per kilo, less than 35 kilos. They are not approved on the package inserts, but there are some countries that are looking to get the regulatory approval within the country. So Brazil has approved tafenoquine for the use in children ages 2 years and above. I believe there's some other countries where MMV are trying to get it approved. But we need more data, in my opinion, but I think it's shown to be safe. Just to show that this 300 milligram dose, if you look at the really old data from the 1990s, the PK data with tafenoquine, the 300 milligram dose is equivalent to low dose primaquine. Oh, sorry, I just want to point out that the radical cure rate, and we can't really say radical cure rate, we'll just say the cure rate, because when this study was performed, we weren't routinely differentiating relapse and new infection. But we see with a 6-month follow-up that you get a 74% cure rate compared to primaquine low dose, 93%. And this is Southeast Asia, sorry. So I'm focusing on Southeast Asia. But here in Africa, we also see low cure rates, but of both. And in South America, low cure rates of both. So this led us to think, well, why is the cure rate lower? And just to note that GSK did choose the 300 milligram dose of tafenoquine because at that time, they're very concerned that with the G6PD biosensor, maybe there might be mistakes. And you might accidentally give the G6PD intermediate person a tafenoquine dose. And we know you cannot take it back. So they opted for the lower dose, or the low dose tafenoquine. And then there was the inspector trial in Indonesian soldiers, where they gave 300 milligrams of tafenoquine. But just remembering that the soldiers in that study had, I think, a mean weight of, was it 80 kilos? They're quite heavy. And we know in Southeast Asia, the mean weight of our patients are about 50 to 55 kilo. So it could have been that they had a lower milligram per kilogram dose, because this was not weight-based. This was just a set dose of 300 milligrams. But it was given with DP, dihydroartemisinin piperacin, and not with chloroquine. So that raised question about drug-drug interactions. So there's two questions now. Is it the dose? Do we need to make it weight-based? Is it the dose 300 milligrams? Maybe it is not high enough. We should give 450. Or is it a drug-drug interaction between DHA piperacin with tafenoquine? Those are the questions we're trying to answer now with research. The TEACH trial looked at tafenoquine in children ages 2 to 15 years old. They wanted to include all the weight ranges, so including 5 to 10 kilo, but they were not able to recruit any participants at least 2-year-old in the low weight ranges. But this is the number of participants, about 50? And they looked at these doses, weight-based, and it's approximately 5 to 10 milligram per kilo. But just to show that you cannot really look, they did give efficacy data, so they did give cure rate, but because there's only 50 participants and across different countries, I won't present that because I don't think it's, you need more evidence to show that it is efficacious. Okay, so what do we need to improve in radical cure? We should answer the question, do we need a higher dose? Is there a drug-drug interaction with DHA piperacin? And we need more data in children, especially less than 2 years old or less than 12 kilos, because we know that recurrences or relapses are much more common in children less than 5. Much more common. I'll just give an overview of the SEADOT trial. That's the Southeast Asia Dose Optimization of Tafenoquine trial. It is funded by NIH, so we've been partially affected by the recent issues in the US. But our main question is, if we need a 50% increase in dose, it means, should we be giving 450 milligrams of tafenoquine instead of 300 milligrams? And then we will follow up for 4 months, because in the studies that we've seen, that we've run it in the past, we see that 90% of the recurrences happen within 4 months. And a lot of the countries at the time when we were reviewing the protocol, they said that the 4-month follow-up was more feasible than 6 months. We have a lot of secondary objectives, but just to point out, we will look at submicroscopic vivax. We're looking at safety and tolerability, day 7 methemoglobin. We're looking at population PK and failure, PD, pharmacodynamics. We'll look at the CYP2D6 status. We'll do some exploratory analysis on tafenoquine metabolites. And we'll also look at maybe recrudescence here. So this is the proposed sample size. We're currently working in 4 countries, Cambodia, Laos, Thailand, and Vietnam in alphabetical order, and total of 700. So initially we had included Myanmar, but that wasn't allowed to be included in the trial, so that we are actually recruiting along the Thailand-Myanmar border, which includes Myanmar population anyway. But that is why we have an increased sample size in Thailand. So just a quick look at the inclusion-exclusion criteria. I think many of you already know this. We're looking at P. vivax monoinfection by microscopy. At some sites, we understand the patients are coming from very remote areas, so we are actually using screening with RDT, and we can include using RDT. I think it's very interesting with each country having the different malaria programs, implementing different I guess, treatment strategies like mass drug administration with Paramax. There are many programs that impact how we recruit and even where we recruit. So that's been an interesting process to be flexible with our inclusion criteria in the last 2 years. You had to have a fever or history of fever in the last 7 days. Of course, G6PD normal, but more than 70%, so not even intermediate. We have a weight and age limit and follow-up for 4 months. We do not include pregnant women or those who are lactating or people with severe anemia. And also we exclude people who had blood transfusions in the last 4 months. So most of the countries are using chloroquine, and the only country using ACT is in Laos PDR. They're using artemether lumefantrine. We have 2 groups, 300 milligrams or 5 milligrams per kilo. The other group is 450 milligrams or 7.5 milligrams per kilo. And this is a weight-based dosing. This is just the study diagram. I'll just show you the follow-up. Sorry, it's a little bit blurry. We give tafenoquine with the schizontoside on day 0. We follow up until the parasite is cleared, so day 1, day 2, day 3. We have a follow-up weekly, day 7, day 14, 21, and 28. And then we follow up at month 2, 3, and 4 before we stop the study. A lot of the blood work is done by dried blood spots. So we do intend to include some of the work that Sarah's doing right now. Okay, so these are the study activities. I think I'll skip this because it's pretty self-explanatory. And just to show a study timeline, because this has been really challenging. Normally, if we implement a study, we would do all the sites at the same time, have an investigator meeting, and everybody goes to implement the study. But in the current situation, we've been implementing one site, almost one per year. So the implementation is very different. All right, let's look here. Here's the grant start date. We submitted study documents pretty soon after the grant started, but actually, these are the colors. Submitted in Cambodia in Q3 of 2024. We started on October 25th for recruitment. In Laos, we submitted in Q1 2024. We started in July. In Thailand, we submitted in Q4 of 2024. We did not start until Q2 of 2025 because of drug import, the process, because the government restructured and changed the drug importation regulations, and that required us to do different paperwork. And in Vietnam, we're on our 3rd application because of government restructuring. So we applied here, and then after a change in the government, we reapplied, and then last month we've needed to reply again to reapply for ethics approval at the local, then to the national, and then to the regulatory drug body. So it means that in Vietnam, we actually did the site training in August this year, but we probably will not start until next year. And we are halfway through the study. So just explaining the logistics. Okay, what is our progress? We have recruited 22 in Cambodia. We have stopped recruitment because it's very, very slow because of the progress towards elimination, which is a good thing. In Laos and Thailand, in Laos, we started last year. After some slow recruitment, we've now recruited 55 cases, all in Samoy. So in Cambodia, we recruit in the Siampang area, which is along the border with Laos. In Laos, we're recruiting in Samoy, which is along the border with Vietnam, central Vietnam, where there's an outbreak. In Thailand, we are recruiting in Tak province. I think I've lost all my spots. So, in Cambodia, we are recruiting I think in this area. In Laos, we're recruiting in this area, this little notch. No, that's Thailand. We're recruiting right here. And then in Thailand, we're recruiting here in Tak province, right here, Mae Sot. And in Thailand, we have 2 sites. We're working with SMRU and also Mahidol Vivax Research Unit with Dr. Jetsamon. So the DV-BD may have heard about it from Dr. Wanlapa and Dr. Jetsamon. We're working in Ta Song Yang, Umpang, and in Wangpa. Actually, not Wangpa, in Meramat. So, and in Vietnam, we're actually working in Can Hoa, which is about here. So we have recruited a total of 132, and we've screened 267. So what is our primary endpoint? We're looking at 4-month efficacy, and we have had 5 recurrences so far. That's about 4% of the recruited. Safety endpoints, we have had no AE or serious adverse events, in the first 70 participants, because we recently had a meeting with the Data Safety Monitoring Board, and we did our an analysis. So out of the first 70 participants, we had quite a lot of GI symptoms, 29% abdominal pain, 18% nausea or vomiting, but most of the symptoms were reported from one site. So it might be a reporting issue or even a dietary issue. We'll have to wait to see what other data come out. We've had 9 people with low hemoglobin, but all were asymptomatic. We have had no large hemoglobin drops, and the hemoglobin adverse events were equally divided among the sites. So we're seeing that tafenoquine is relatively safe in this group of people who have G6PD activity more than 70%. I think the operational research that the countries here have done show that using G6PD biosensor is safe and straightforward. So what is next? Of course, as an investigator, my goal is to complete the study successfully. We need to close the under-recruiting sites, and we'll need to open sites where we can recruit patients. So we're looking at Indonesia as a recruitment site. It does require a lot of follow-up, a lot of working together with the national malaria programs, with the provincial health departments and other departments in the government, so that we can take advantage of any patients that get malaria. And then I had some points I wanted to make here. Maybe that's the next talk, but just to say that, this work is really at the individual level. We will look at relapses versus reinfections when the study is over, and that's because we're doing individual work with paired samples. And I understand that at an operational level or population level with surveys, it's a very different way of working. And this kind of work may or may not be feasible at a population level. But we do intend to do the whole genome sequencing that Sarah and Jan shared earlier for the study. There are a lot of people to thank, so appreciate the support that we've gotten from everyone so far. Thank you.
Okay, thank you, Cindy. So one person's bad news is another good news. I heard, we had to stop in Cambodia because there's not enough cases. To me, that's very nice news. And again, it's good that we come here and you sort of hear things being shared, and ultimately it's all positive, really. Thank you. Tan, yes.
Thank you. Thank you for very fruitful presentation. Once again, I would like to know your idea, because sometimes some people mention that there are some interaction between Tafenoquine and ACT, Piramak, and so on. So sometimes people say no problem. And actually, do you have evidence on that? This was first question. The second is you said inclusion criteria. You take those fever or history of fever 7 days. If the asymptomatic, it still can include or not. And maybe I lose our presentation. Why we create 50% of Tafenoquine instead of double or maybe 20%? Thank you.
So sorry, I might go backwards with your questions because I can't remember. So the last question is about doubling the dose. James Watson did some modeling to show that we could actually improve the radical cure efficacy significantly. We could improve it by 90% if we just increase the dose by 50%. We also know that when you double the dose, you get many more side effects, especially gastrointestinal. So that's why we decided for the 50%. We think we'll see a benefit. Your second one was if we could recruit asymptomatic. So this study was developed in 2019. We applied 4 times for funding. So back in 2019, all of us were in a very different situation. It was easy to get symptomatic cases, and now it's quite difficult. But I think we will, if we did asymptomatic, it requires active detection. I mean, that's a good question. I don't think we'll change it because we're already here. But maybe if we develop the protocol today, it would include asymptomatic. And I'm sorry, what was your first question? I forgot it. Oh, yes. ACT. So the drug-drug interaction. There's a study being done along the Thailand-Myanmar border looking at DP tafenoquine, chloroquine and tafenoquine, and artemether-lumefantrine tafenoquine. Hopefully they'll have some results soon. They have not finished recruitment. So that will come maybe next year. And also there's the Tidor study that's being run by Menzies. They'll have artemether-lumefantrine, but no answer yet. But they might have some preliminary data in their effort trial.
Okay, a quick question. You say that 5 patients is recurrent, and this is for low dose Tafenoquine or high dose?
We don't know because
but you don't know.
Double blind, double dummy, nobody knows. So we will know at the end of the study. To be a surprise.
Oh, just surprise
also
at the end.
Reduce the bias.
And also you don't know whether this is ACT plus Tafenoquine or chloroquine with the 5 recurrent here.
Yes, we'll
blind
know.
As well.
That one we'll know because we know which country they're from, but I didn't share the data today, so.
Okay. Hopefully surprise later.
Okay.
I just want to add that you stopped Tafenoquine in Cambodia because you say that there's a number of cases low, but it's not really.
Okay.
Because you are selected 7.5 GCPD activity. The rest of malaria vivax in Cambodia right now most likely is lower because before we never include for radical cure treatment. So now the time for look at all these people, but Tafenoquine is not looked at for that. So it's a pity. Now because your condition, but just let you know that currently we have most likely people come with the low GCPD activity. And we need, but we still to treat primaquine anyway. We had to hospitalize. We had to go something else. Yeah, thank you very much.
Yes, I agree. It's always a pity when we cannot continue. But I have to agree with Olivo in this situation that If you do have low recruitment, it also means that there's been good effort towards elimination. And also just to make a point that the patients are coming from very remote areas. It's sometimes we cannot recruit because they just cannot follow up. And for example, we started in Nakai, but it's a 1 hour boat ride, fast boat. The slow boat is 2 hours. Yeah, yes, so yes.
Border with Laos, all is a river. So you have to cross a river, take time for transportation, yeah.
I mean, maybe if there are outbreaks, we could potentially look at places where we could recruit. So happy to discuss.
Great. Any more? Closing bids? Okay. So thank you very much, Cindy. And there's a slight change in program with respect to the agenda. We're going to take lunch now. And how much time do we have for lunch? 1 hour.